Good day, class. Today I just want to cover some of the things we have coming up this week and also just make sure you guys have a little background on this week's topic for the shoulder. So let me go over here to our outline of the coming weeks and just to cover what's going on. So for week 6, you have chapter 22, which is on the shoulder. um, and lecture. So the lecture is just going to be at the end of this. I'm going to cover a few slides on the PowerPoint, just some of the more important things that I think you guys need to know. Discussion board will be due on Wednesday. It's on shoulder injuries, and I'll talk about a little bit more about that. Assignment 6 is Olympic shoulder injuries, and I'll cover that right now too. And then also your second article review is due on Sunday as well, and that's for youth pitching for pitch type and count. And then you also have your quiz 6 as well. So let me just come over here. So this is your assignment for the week, Olympic shoulder injury. So it says choose one common shoulder injury seen in the Summer Olympics. So if you're not if you want to look at different variety of different sports, you can't really remember a lot of the common the events that require a lot of shoulder activity. Just go to olympic.org and you can look up the different events that they have there. And it says write a 1 to 2 page paper that describes the injury and gives examples of the different sports events where the injury is seen. What are the similarities and differences between the sports events and the mechanism of injury? What are short and long-term treatment options? What prevention methods can be implemented? Are there any prophylactic taping, bracing techniques? So basically, you have to look at what are the typical injuries that could occur in Olympic sports. So Olympic lifting, there's javelin, there's shot put, there's a lot of either throwing events or strength and power events that require the use of the shoulder. So I just want to give you a little bit different take on how to look at injuries. You know, it's I'm not too interested in you explaining the history and background of the event. Mainly, just give me a description of, what the event is like, what's required of the athlete, and what are some typical injuries that you could see with this event, and then obviously answer the rest of the questions that are on there. And then make sure you get to this part as well, the prophylactic taping and bracing techniques. So, those are things that you want to look up and make sure that you understand what are some current techniques and current methods that athletes are using to help protect and prevent injuries. The article, um, let's see. Okay, so it's pulling up now. So the second article review is on the article called um, Effective Pitch Type, Pitch Count, and Pitching Mechanisms on Wrist and Elbow and Shoulder Pain in Youth Baseball Pitchers. So this is a pretty interesting article. It'll definitely bring up some debate and some things to think about. So I've listed some questions here. Make sure that you answer them as you're writing your review here. And again, I'm gonna give you guys the option. You guys can answer these as questions, so you can write down the question, put down your answer, or you can write this all as an essay format, just making sure that you answer each of these questions. What isn't an option though is if you are directly quoting from the article or paraphrasing, make sure that you're referencing that. Make sure that you're citing, especially when you're taking direct quotations. Make sure that you're citing and that you have a reference page listing this article. And if you use your book or anything else like that, make sure you list that as well. I'm going to be looking for that this week because next week your critical assignment is due. And on that assignment, you have to reference and cite the article that you chose and your textbook or any other resources that you use to to support your points. So just start getting used to that. If you have any questions about that, just email me or start a discussion board. As far as APA format goes, you guys need to set up a time with the librarian. You can do that online so that if you're still not too sure how you're supposed to be citing and referencing, that you get some help with that. Okay, and okay, let me go here. So today we're going to be talking about the shoulder complex. I just want to go over a few points, just some things that I was thinking about as I was going through this PowerPoint. Um, First thing is make sure that you review the anatomy. So clavicle, scapula, and humerus. Those are the three bones that we're pretty much covering within the shoulder complex. You have those three joints. The um, Within the shoulder joint, you have the scapulohumeral joint. You have the AC joint, the acromioclavicular joint, and you also have the sternoclavicular joint. And there's also one other joint that's really not mentioned here. Let's see, I didn't put it on there, but the scapulothoracic junction. It's not really a joint because there's really no two bones touching. But that junction, the junction between the scapula and the thoracic spine, there's a lot of musculature that connects those two structures, and that's why it's still important when we talk about shoulder injury prevention and just normal movement of the shoulder. So make sure you review this anatomy, read that in your book. So when we get to the ligaments, the first set of ligaments that are listed on here, the SC joint ligament. So this is not really a good picture. This is a better picture here. So here we have the SC joint, and I think yeah. So here the words are cut off a little bit here, but this would be the anterior sternoclavicular ligament. Back here would be the posterior clavicular ligament. So just if you're not sure what you're looking at, this is if we're looking straight down someone's body. So this would be the anterior portion. This is where the ribs are, and here's where the spine is back here. So as it says on here, these are very strong ligaments. There's not a whole lot of motion um, right here in your SC joint. So anytime there's a strong force that comes to that area and you have an actual sprain, it's going to be pretty important to recognize that because you do have some important structures right behind your clavicle. You have some arteries, you have some veins, and then you also have your esophagus there. So if there's an anterior displacement, not too much of a big deal. There's going to be a lot of pain, but not a big deal. If there's a posterior dislocation or translation, that's a bigger deal. That's an emergency. Um, you don't want to compromise any of the structures that I mentioned before there. So the next joint is the acromioclavicular joint, the AC joint. So that would be up here. So let's see in this next picture. Here's a little bit better picture. Sorry, here. So the AC joint, like it says here, there's the anterior, posterior, inferior, and superior portions of the AC joint ligament. All of those are supporting that joint so that it doesn't move superiorly, inferiorly, posteriorly, or anteriorly. And when we get to that pathology, you guys will see that usually the main direction that it's gonna dislocate or sublux is gonna be superiorly, and you're gonna see that because of the deformity that's on there. So the other things that we have to look at are the joint capsule. So the joint capsule is reinforced by the glenohumeral ligament. So like I mentioned with the knee, and the MCL. The major ligaments are going to be pretty much threaded within the joint capsule. That's why the joint capsule is so important, and it's usually going to be a casualty of an injury to one of these ligaments. You can't really have a glenohumeral joint um, subluxation, dislocation, or just a sprain without also involving the joint capsule. And here it just gives you an idea of what portion of the joint capsule would be injured. So, for example, it says posterior of the joint capsule would be taut with flexion, abduction, internal rotation, horizontal abduction, or any combination of these. So, anytime you're in these positions, that's when the posterior portion of the joint capsule is stretched. So here are some, when we look at that glenohumeral joint ligaments, they're broken down into basically the position that these ligaments are in, or I'm sorry, the location of them. So you have the anterior glenohumeral ligament, the middle glenohumeral ligament, inferior glenohumeral ligament, and posterior glenohumeral ligament, and it just tells you when they're in most tension. So that's where you know how they'll get injured the easiest. So anterior glenohumeral ligament, or it says SGHL because it's also labeled superior glenohumeral ligament, is taut or tight, or you have tension and extension, abduction, or external rotation. So once your arm is in any of those positions, you're gonna be putting the ligament in a little bit more risk of being sprained. So here we have more important anatomical structures. We have the bursa, the subacromial bursa. That's going to be, like the name kind of alludes to, it's under the acromion process, so it would be right under here. Um, that's going to be also a factor when you're talking about subluxations, dislocations, or or just sprains to the shoulder joint. Then you also have your brachial plexus. The brachial plexus is made up of these 5 nerve roots, and here you see the um, once the nerve roots exit out through the neck and they go down through the shoulder, then you have these are the peripheral nerves. So this is what they're labeled after they've exited the neck and past the shoulder region. So all these, as you can see, they pass behind the clavicle and they pass through close to the subacromial space. So anytime you have a sprain or a strain at the shoulder level and you get inflammation, there's not going to be a whole lot of space because there's already a lot of structures within this area. So getting neurological symptoms is not very uncommon when you have any type of shoulder injury. Like it says here, it says common sites for impingement of these structures are between anterior and middle scalenes, first rib, and the clavicle. So as you see these nerve roots coming down through here, they can be trapped in between the anterior and middle scalenes, and then also between the first rib and the clavicle. And there'll be athletes who, um, have a problem with their first rib where it's not rotating correctly, it's not moving right, and that'll start causing some neurological issues. And it's typically because their first rib might be a little bit larger or a little bit more hooked than normal people. Next thing is scapulohumeral rhythm. So here the movement of the scapula relative to movement of humerus through abduction. So in this next figure, it kind of gives you a description of what this is talking about. When you're moving your shoulder from, let's say, neutral, 0, to about 30 degrees of abduction, you have no scapular movement. So there's no movement within the scapula at from 0 to 30 degrees of abduction. So here, this is all movement of the humerus. From 30 to 90 degrees of abduction, the scapula abducts and upwardly rotates 1 degree for every 2 degrees of humeral elevation. So from 30 to 60 degrees,